So thank you, everybody. We're going to get started with our next session, and I'm delighted to introduce Lisa Fabini-Kaiser, who's joining us via Zoom. So Lisa, welcome, and let's give her a big, warm owl welcome.
Hi, I'm Lisa Fabini-Kaiser. Oh, thank you. So happy to be here. Thank you for having me. I'm really sorry I couldn't be there in person. Unfortunately, I have small children who like to get sick a lot. But I'm really grateful to both Susan and Jim for allowing me to present virtually, and also to my colleague, Dr. Lily Fishman, who is in the audience, hopefully, who can talk with you more if you guys are interested in learning more about what SRF does. So I'm going to get started. Hi, I'm Lisa Fabini-Kaiser, and I represent SENS Research Foundation. Hopefully you know who we are, but we are an American nonprofit dedicated to tackling the epidemic of age-related disease through a unique approach of damage repair specifically. And thank you for joining me today. Considering we at a conference here discussing longevity, most of you are probably aware of this kind of data. We as a global community are getting older. And while we are aging better than our predecessors, it should be noted that our population is currently the oldest it's ever been. And of course, our population is getting older. Our health span has not kept up with our lifespan. And this graph shows by 2100, less than 80 years in our future, 1 in 4 people will be over the age of 65. We are getting older, we are living longer, and also significantly increasing the amount and degree of age-related disease that is present in today's world. It's an epidemic that impacts every one of us, either directly as we ourselves age, or indirectly on family members who we care for as they decline. Outside of the impact to individuals, a large, unhealthy, and debilitated population of people will strain our workforce, our healthcare systems, our economies on a massive scale. We are already seeing these impacts. Think back to 2020 with the COVID pandemic and the sheer number of elderly persons who were hospitalized or died in their homes due to an inability to access healthcare. We learned that our elderly are at a greater risk due to their multiple comorbidities and overall frailty. And the system failed to support their overwhelming numbers, both in times of critical crisis and in follow-up care. And because of that, we have seen enormous deaths, specifically in the aged population from COVID. And this isn't new information. We've known about the risks associated with this shift in population dynamics. We've known that elder care is an enormous part of our healthcare costs. We understand that age-related diseases such as Alzheimer's, cancer, atherosclerosis, osteoporosis are not only deadly, but also drain us of resources, the most important one being those people affected and killed by these diseases. Despite knowing this, we have yet to solve the problem. And I argue that we as a global community are not working together and are not funding this work as well as we should to be able to make real progress. I understand that aging is a complicated issue. There's a lot of parts to it, but we should be making more progress than we are. We are in a golden age of biotechnology. The longevity industry, despite an economic downturn, is booming. We have more startups and nonprofits than ever before, and yet our progress still feels incremental. Why is that? Is it because we are getting swept up in the brave new world of things like genetic reprogramming without addressing more comprehensive and accessible solutions now? Is it because there is a race to find the best aging clock, which, while incredibly interesting and useful from a data standpoint, doesn't actually attenuate any disease state? Or maybe it's because we are all pulling in our own directions, not collaborating, not using the resources that already exist, and rather trying to individually reinvent the longevity wheel from our own perspectives. And of course, SRF has its own viewpoint that we've been advocating for the better part of 15 years. And we continue to do so and will continue to do so. This is a simplification of what causes diseases and disabilities of aging from an SRF perspective. Our bodies operate normally with normal metabolism going through all chemical processes that combine in intricate ways to keep us alive and functioning. Over time, those complex processes create damage, normally, naturally, because we are not perfect, right? Just like how our chopping knives dull over time, even with proper use, and have to be resharpened and eventually replaced, We too gather damage through our lives. That damage at a certain level becomes disease or pathology. Current medicine focuses on the pathology and sometimes the metabolism. And here's what they tell you. Adjust your lifestyle according to what chronic disease you've either inherited or developed through your life. Take your supplements and your prescription medications to offset the symptoms of your disease. And generally, and maybe most importantly, accept that your body no longer functions like it should and you are officially in decline. How many times have you gone to a doctor and you say something aches and they just say, yeah, you're getting older? That is unacceptable to me and to us at SRF. Suddenly, you're at the doctor's appointment and you are told that today is probably the best you will ever feel. And that trend just kind of continues. And it's awful. And SENS Research Foundation has a different approach. This is a map of metabolism, roughly. Roughly because, as you can see here, metabolism is complicated and not fully understood. Messing with metabolism has unknown downstream effects. This may be best visualized in the excessive list of side effects for many of our prescription medications. In fact, I would argue for most of our prescription medications. The laundry list of side effects seems to never end and is said very quietly during the commercials. So you try not to focus on them too much when you see the happy, smiling people on screen. But we argue that this is not the area where we should be intervening. Not yet, anyway. We don't have the knowledge yet to even know what we don't know in regards to human metabolism. Intervening at the pathology stage isn't useful either, though. Treating symptoms will never tackle the underlying causes of the disease. And while it might make you feel more comfortable, it won't make you healthy. It won't make you actually get better. Our healthcare system is really sick care, focused on these pathologies and providing only rudimentary approaches to alleviate suffering as you continue to decline. SRF focuses on the damage. It's not messing with your body's normal metabolism, and it's not waiting until you start showing painful and debilitating symptoms of a disease to start treatment. Damage is in your body from the moment you are alive. It is not the creation of the damage that is harmful. It is the accumulation of the damage. Removing that accumulation through targeted biological strategies will strike at the root cause of these diseases without all the nasty side effects and without waiting for you to present with symptoms at the doctor's office. We postulate that there are 7 types of damage that occur in our bodies and drive the diseases of aging. Some diseases are complex, stretching over multiple strands, such as Alzheimer's disease. Some are more simple, only residing in one strand, but being really complex in and of themselves, like cancer. If you are interested in learning more about these types of diseases and damages, and how they drive disease, check out the Life Noggin channel. It's a YouTube channel. We partnered with lifespan.io a couple years ago now to create really great videos on each strand of damage. They're a bit science-light, so if you're expecting super technical information, just go to our website at sens.org. But it's a really great way to kind of get a gist of what the strands are. It's entitled Fighting Aging with SENS. But regardless of what kind of damage is present, all diseases and disabilities of aging are damage-driven, and we at SRF aim to eliminate them. This is our vision. We fund direct research at our laboratory in Mountain View, California, send grants to universities worldwide, and make investments in biotech companies which focus on our damage repair approach. Because our mission is to impact the diseases of aging, we also work to translate our research into real-world applications and therapies. We spin out companies ourselves and license our IP to teams who are capable of taking it to market. And it's not enough to just fund this research. We also have to teach our next generation of scientists how to study aging, because our medical systems aren't doing this enough. We have a robust education program, which brings the best and brightest young scientists into our labs and labs doing damage repair work nationally, training them to view age-related disease as the epidemic it is, and encouraging them to choose a career inside of our industry. Our programs run from a 3-month internship over the summer break to 5-year PhD programs that are hosted inside our research center. Every year, we see students from our program getting hired at their host labs, continuing their work on aging, or entering into medical school with a robust understanding of the underlying mechanisms behind some of our toughest age-related challenges. STEM education, teaching these young people how to view aging as a disease and how to target it in the laboratory, will be critical to our global success. And while this is absolutely our mission with the education program, it's also reaped other benefits. Individual companies, for profits and nonprofits, can spend anywhere from 4 to 20K to hire one single employee, with an average time of 36 days to onboarding. For small startups, those costs can be noticeably detrimental to their operations. Our education program does the recruiting, the screening, and the interviewing to find the best and brightest young scientists in the country. And we place them in these laboratories, both for profits and nonprofits. This saves enormous time and money and supports the longevity industry from the ground up. We've had enormous success placing these students in labs such as Dr. Evan Snyder's, for instance, where he has really relied on our low level support. And by low level, I don't mean in terms of impact, I mean in terms of money. A student, even a well trained, really competent student, is significantly cheaper than hiring a fresh graduate as an RA. So we've really been able to make some big impacts in these longevity laboratories just through our education program. If this interests you, consider funding one of our students. We have amazing students applying every year, but we can only place a small fraction of them in labs due to financial constraints. We have PIs asking us year after year for more students. These students are highly successful, often getting hired in their host labs, going on to medical school, becoming doctors, creating startups of their own. We'd love to support more of them in their careers, but we can't talk about that until we talk more about the science as well. So we have multiple internal teams. Our internal apoptoSENS team studies senescent cells, which are main drivers of many aging diseases, as shown here. They impact neurodegenerative diseases, osteoarthritis, diabetes, and cancer, just to name a few. Our apoptoSENS team has three primary foci when targeting senescence. How do you identify and track senescent cells? How do you target senescent cells? And how to safely remove senescent cells from the body? They are developing immune-based therapeutics with those goals in mind to cure and prevent senescence-driven diseases. And as an aside, some of you may know of the recent passing of Dr. Judy Campisi, who was a phenomenal researcher at the Buck Institute and was a real pioneer in the space of senescence. We were incredibly lucky to have her on our scientific advisory board for over a decade, and she was the mentor to our current primary investigator, Dr. Amit Sharma, who runs the program at SRF. We really hope that we can just help keep her legacy alive, even just a little bit, compared to how much she has done for this field, really, in her work in senescence. Our MitoSENS program is also one of our internal programs and is currently our longest running program. While producing our energy, mitochondria release free radicals, which damage their own unique DNA as it is housed outside of the nucleus. The mutations and damage created in their DNA reduces their ability to produce energy and creates the disabilities and frailties often associated with aging. Our MitoSENS team is working on copying mitochondrial DNA into the nucleus for protection, and as the leading authority globally on mitochondria, have expressed all 13 mitochondrial genes, successfully replicating one of them in the nucleus in vivo. The team is also targeting mitophagy, or how dysfunctional mitochondria are removed, to promote their turnover for more optimal cellular functionality with a small molecule drug. Like I said, we focus also on translatability, not just basic research. And these are just two of our internal programs at our research center, but our work is not intended to remain in the laboratory. So this is a great example of our paradigm in action as a therapeutic. Atherosclerosis, it is the leading cause of death worldwide, responsible for 44 out of 100 deaths, and is largely driven by damage in our lysosome strand. It is caused by the aggregation of a specific type of cholesterol, one that our bodies accumulate because we can't break it down. When this cholesterol accumulates in macrophages, the cells engorge and become useless foam cells, which lump together to form arterial plaques, driving heart disease and stroke. Your body is doing what it is supposed to do. It's encapsulating the cholesterol out of your bloodstream, storing it away where it can't cause additional damage. The issue is that the storage mechanism becomes too full and becomes a source of damage itself. Our latest spin-out, Cyclarity, is led by a previous CEO and vice president of research. Their small molecule drug targets that specific cholesterol, that damage, rejuvenating the bloated foam cells and degrading arterial plaques. It has the potential to eradicate atherosclerosis and change how we view seemingly intractable diseases of aging, and they are headed into clinical trials. The atherosclerosis market itself is enormous. The diagnosed cases of cardiovascular disease has a global market of 60.9 billion USD by the year 2030. That number does not include the 42% of adults who are pre-symptomatic, pre-pathology, and pre-diagnosis, but who still have measurable arterial plaques and are headed for serious age-related decline. Not only is atherosclerosis the number one killer globally, it's also extremely expensive. Our medical system and international medical systems as well were not designed to bear the weight of the sheer number of atherosclerotic patients. And the more our population ages, the greater that strain will become. And what are we doing about it? There are many prescription medications currently on the market. Statins are really well known, highly prescribed. Johns Hopkins suggests that over 200 million people worldwide currently take a statin to reduce cardiac events from atherosclerosis. And that number is, of course, predicted to rise. But this is still treating the pathology. Statins may reduce blood cholesterol levels, but it doesn't repair the accumulation of cholesterol already in your cells, degrading their function and building these plaques. It merely slows, not prevents the future accumulation. Cyclarity's drug has the potential to revolutionize the prescription drug market for cardiovascular disease by being protective, preventative, and curative in a way that no drug currently on the market is capable of. Here's just a glimpse of Cyclarity's data. Their unique drug, UDP-003, removes their accumulated cholesterol, rejuvenating diseased and dysfunctional macrophages, decreasing the accumulation of damage that has already occurred and reducing the damage load in the future. Imagine a world, if you will, without atherosclerosis, where the disease can be treated prophylactically before the disease presents as a pathology, for your first heart event or your first stroke, before you even know you're sick, because we are removing the damage before it becomes a problem and starts impacting the quality of your life. How many lives would we save? How much in medical costs, in daily prescription medications? It would change how we do medicine, how we view aging, and who we consider patients and how we treat them. This is at the heart of my foundation's mission, tackling each disease of aging as an accumulation of damage to change the global perspective on these diseases and build a path forward to better, longer health span for everyone through medical intervention, yes, but also through showcasing what is possible if we move away from sick care and towards healthcare, where we are treating patients not because they are showing signs of being sick, but that we recognize that everyone has damage that is making them sick. We just can't see it yet. And if we can treat it before it becomes a pathology, how much better we would treat our people, our patients, and how much better our people's quality of life would be. Okay, so I think this is my last slide. As a 501c3 nonprofit, we operate almost exclusively on donations and grant funding. If what I said today resonated with you at all, if you are interested in seeing what a damage repair approach to aging can reap on the global stage, sign up for our newsletter, follow us on social media, and consider contributing to our mission in any way you can. Part of our goal at SRF is not to do this by ourselves. I mentioned at the beginning of this presentation that we aren't collaborating enough. A big focus of SRF for the last 2 years since I've been the CEO is how to build bridges, how to create collaborations where none existed before, and how to reduce the overhead for new initiatives. Administrative and operational costs are enormous. They just are. It's a huge drain on what needs to be going towards the research and the technology development. So we are doing our best to try to build those bridges, to try to reduce those overhead costs and provide a path forward for new startups, for new research, for new teams looking to make an impact. So if you have ideas that you would like to talk to us about, if you would like to help build these bridges, if you would like to help be a collaborator, we're all ears. We'd love to listen. We're already working with the Parkinson's Foundation and with Michael J. Fox Foundation to try to build more bridges specifically for aging and Parkinson's. And there are so many other avenues open to doing the same kind of work for the other diseases of aging. Thank you for your time. Thank you to Jim and to Susan for the organization of this and for having me on stage. And again, my colleague, Dr. Lillian Fishman, is in the audience and would be happy to talk with you more about what we do. Thank you so much.
Thank you, Lisa. That was really amazing. I'm sure we have some questions in the audience. Yes. Leo.
Great talk and overview. I have a rather specific question. So for the heart disease drugs, in your list, PCSK9 inhibitors have a red cross for prevention, but people who have PCSK9 mutations that lead to less production of this protein are 10 times less likely to have heart disease. And if you do gene therapy to delete PCSK9, there's some, do you have a head-to-head comparison? And this new drug is better at preventing heart disease and PCSK9 ablation?
So it's specifically removing the type of cholesterol. So it's not metabolism, right? So what you're talking about is something that we absolutely don't do, is what we call messing with metabolism, which is gene targeting. And while I think that that has some interesting, I'm really interested to see where the genetic field goes in terms of how they can manage things. But I think that we still don't know enough about downstream effects of what's impacted and where and how. The small molecule drug that Cyclarity is working on specifically targets that type of cholesterol that builds up and takes the macrophages that have become foam cells and breaks down that cholesterol specifically and removes it from the cell and flushes it out of the system through typical trash removal. So it's absolutely not genetic modification. And in our opinion, at least, small molecule drugs, right now it's intravenous, but they're working on creating it as an oral drug, is much more accessible right now than the gene targeting work that's being done. That might be maybe 10 years out, I think, from really being widely available to the community. I don't know if that answered your question per se.
Yeah, and this will be more accessible than a gene therapy for PCSK9, I understand. Yeah, thank you.
I also want to say about Cyclarity's drug is not only are they running with this, so they're one of our prior CEOs and our prior vice president of research are running the company. And one of the reasons they decided to leave SRF to run Cyclarity is because they are mission driven to make sure that the drug that they create is accessible to everyone. So they also have investors, specifically Kaizu, if you're familiar with Kaizu and Michael Grieva, who are also interested in making this accessible. So their goal is a $10 pill that you take like twice a year. They're not there yet, to the best of my knowledge, but that's their goal. And I love that they're investors. It's not just the heads of the company that are invested and interested in making sure that that happens, but it's also the investors that they've are working with directly, who are deeply invested, no pun intended, in making sure that that drug reaches market at an affordable cost, which I think is also really integral to our mission at SRF, is to make sure that what we create reaches everyone. And it's not just for the wealthy, and it's not just for the people who can drop $10,000 on a treatment plan, right? This is supposed to be something that is accessible as soon as humanly possible at an extremely low cost.
Other questions? No? All right, let's give Lisa another hand. Thanks so much, Lisa.
Happy to meet.
Bye-bye. Take care, and I hope you feel better soon. Bye.